The Sociology of Health. The World Health Organization defines health as a state of complete physical, mental, and social well-being. That's setting the bar pretty high. Most of us probably don't always enjoy a complete sense of physical, social, and mental well-being, but it does remind us that health is about more than just the state of our bodies. Epidemiology is a term which refers to the study of health and disease across a population. The photos, by the way, are from a Tumblr called Women Laughing Alone with Salad. It was started by someone who noticed that magazine articles about health, nutrition, or weight loss for women were almost always accompanied by a stock photo of a woman, alone, seemingly laughing, with a bowl of salad. There's also a companion Tumblr called Women Laughing Alone with Yogurt. Two other important terms in the study of health and disease are morbidity and mortality. Morbidity refers to the state of being sick or having a disease, or the incidence or rate of a disease in a population, whereas mortality refers to death or the death rate in a population. While all of us will die eventually, we are living longer than we used to. Average life expectancy from birth in the United States has increased from 46 years on average for men and 48 years on average for women in the year 1900 to 76.3 years for men and 81.4 years for women in 2019. When we say life expectancy in 1900 was only 40-some years, that doesn't mean most people suddenly dropped dead in their mid-40s. It means you had far higher rates of infant and child mortality. So there were big spikes in the death rate in infancy and early childhood, and then again post 60 years of age. If you lived to 46 in 1900, you had a pretty good shot, actually, of making it into your 60s and 70s. Unfortunately, the COVID-19 pandemic brought the average life expectancy down across all groups. At the time of this recording, almost 600,000 Americans had died from it. Non-Hispanic whites saw a loss of about 1 year of life expectancy on average, Hispanics about 2 years, and blacks almost 3. This is because COVID affected some groups worse than others. Men were more likely to die than women, the old more likely than the young, and non-whites more likely to become very ill or die than whites. We don't know all the reasons why, but social factors ranging from poverty and lack of access to basic health care, to the fact that poorer populations are less likely to be able to work safely from home, to a higher incidence of pre-existing conditions like heart disease or diabetes, all played some role. Unfortunately, COVID is not alone in being more deadly to poor and minority populations. Even before the pandemic, non-whites died earlier than whites, and poor people of all races and ethnicities died earlier than rich people. A child born in Mississippi, one of the poorest states, can expect to live on average 5 fewer years than a child born in a wealthy state like California. Gender stratification actually goes differently here, with men being more disadvantaged health-wise than women, even though they are better off financially. Why? Some is biological. Male fetuses, for example, are more likely to die in utero than female fetuses, and male infants are more likely to die of hereditary disease. Adult men are more likely to suffer from cardiovascular illness, for example. This might be a combination of biological factors and social ones. Men are more likely to smoke and drink heavily. Men are also more likely to die of COVID complications, and they are more likely to be victims of homicide, fatal accidents, and suicide. This last one we'll discuss later in this lecture. COVID-19 isn't the only place where we see health disparities between minorities and Caucasian whites. Non-whites suffer worse health outcomes than whites for reasons ranging from simple economics, health insurance is expensive and minorities are still poorer on average, to persistent discrimination in medication and health care. For example, studies have shown that black patients with serious injuries or painful conditions are less likely to be prescribed painkillers compared to whites, and a 2016 survey found that as many as 40% of medical trainees still believed false information, such as blacks have thicker skin than whites, or blacks have a higher pain tolerance. Neither of these things is true, but it can help to explain why black patients in pain may be taken less seriously. Black patients with heart attack symptoms in another study were shown to be less likely to be taken seriously by their doctors or given appropriate tests and treatment, and black patients with kidney failure or less likely to be placed on transplant waiting lists. These are obviously serious social problems. Discrimination in healthcare isn't just unfair, it is also potentially quite deadly. By the way, women of all races often face the same challenges. Across a range of studies, women who complain of severe post surgical pain are less likely to be prescribed painkillers compared to men who have undergone the same procedure. They wait longer for pain treatment when admitted to an emergency room and are more likely to be prescribed sedatives or tranquilizers rather than painkillers. That last one, being given a sedative or a tranquilizer rather than a painkiller, might reflect an old belief that a suffering woman is simply hysterical or over emotional, rather than really experiencing pain. Similarly, a 2000 study in the New England Journal of Medicine found that women are 7 times more likely to be misdiagnosed or discharged in the middle of a heart attack, in part because heart attack symptoms manifest slightly differently in women, and many doctors are still trained on a model that treats male symptoms as the implicit norm. When taken together, this shows us that minority women may face a double bind when trying to get the care they need. This is one reason why anti-bias training in medical education is so necessary, and why it is important that all patients learn to speak up and advocate for themselves or their loved ones during the course of medical treatment. This chart is pretty interesting. It was published by the New England Journal of Medicine in 2012. These are causes of death per 100,000 people in the population in 1900 versus 2010. You can see some significant changes between what killed us 100 years ago and how we die now. First of all, the total death rate has fallen. People of all ages had a higher risk of mortality back then due to simple things like lack of antibiotics or vaccines. For example, diphtheria, a contagious disease that was a major killer of babies and children, has mostly been eradicated through vaccines, so you don't see it as a leading cause of death in the 2010 column. People, especially the very young and very old, do still die of diseases like the flu or conditions like pneumonia, but our ability to treat these conditions has improved dramatically. Heart disease and cancer are our biggest killers now, and the fact that more Americans die from cancer than used to can represent both good and bad news. We might be more likely to develop cancer now due to increased exposure to environmental toxins or tobacco smoke, for example. That's bad news. But cancer is another disease that tends to strike in middle or old age. If more of a population is dying from cancer, that often means they're living long enough to get it. So, in a weird way, that's good news. The infant who would have died of diphtheria in 1900 can now live into her 80s, where she can die of bladder cancer instead. Since most of us would rather die in advanced old age than when we are young, that can be considered a positive development. The United States spends more on healthcare per capita, per person, than any other country on Earth. This chart shows total per person spending in blue and the amount the government pays per person in orange. Remember, the US has a larger population than most other countries, but that's not why we pay more. Per capita figures take that into account. So that means we're the healthiest, right? Well, no. Among wealthy countries, our health outcomes, measured through things like life expectancy, infant mortality, and patient satisfaction, are actually pretty bad. One simple reason for this is that so many of us will be uninsured, having no healthcare coverage, or underinsured, having some healthcare coverage but still being unable to afford necessary care at some point in our life. In 2019, almost 15% of the US population between the ages of 18 and 64 had no health insurance. About 5% of US children had no health insurance. In other wealthy countries, this really isn't an issue, since most guarantee what we call universal health care, meaning all citizens are given health care as a right of citizenship. It's not free, it's funded through taxes, but everyone is covered and you usually don't pay anything for doctor visits, tests, treatments, or even expensive surgeries. Interestingly, despite the fact that governments in those countries pay to provide care to everyone, our government still pays more per person, even though we don't, indicating that switching to a so-called single-payer or Medicare for all system, wherein all Americans are covered by some kind of government-funded insurance, wouldn't necessarily raise costs in the way that many people would anticipate. I'll explain why in a little bit. One way to measure the health of a population is to look at life expectancy. Our life expectancy is higher than those of poor countries like, say, Mexico or Turkey. Average life expectancy at birth in Mexico is a little over 74 years of age. In the United States, it's around 4 years longer, a little over 78 on average. But if you compare us to other wealthy nations, we aren't doing so well. For example, someone in the UK can expect 3 years on average more than the average American, dying at about 81 years of age on average. And the average Japanese citizen can expect to live about 5 years longer than the average American can. Infant mortality, the death of children under 1 year of age, is studied as another really important indicator of the health of the whole nation because it tells us about the state of maternal health, prenatal care, and public health practices more generally. The United States' infant mortality rates are about 2 to 3 times those found in most peer nations. Our rates of maternal mortality are also double those of other wealthy countries, meaning women in the United States are twice as likely to die as a result of complications of pregnancy or childbirth than women in a country like France. Etiology refers to the cause of a disease or poor health outcome, and the etiology of infant and maternal mortality is varied. Rates of infant mortality, for example, are linked strongly to rates of preterm and/or low birth weight birth, which can in turn be linked to a range of overall maternal health issues, ranging from malnutrition to tobacco, drug, and alcohol use. Other major causes include pregnancy and birth complications, more common when women aren't getting prenatal care, accidents, and SIDS, or sudden infant death syndrome. A lot of those issues, in turn, are compounded by poverty. Why are we less healthy than people in other wealthy nations? Why don't we live as long? One potential explanation has to do with lifestyle diseases. These are diseases linked to lifestyle choices, such as smoking, overeating, or lack of exercise. Some good news is we smoke way less than the OECD average. Most EU or European Union countries, for example, still smoke at higher rates than do Americans. We also drink less alcohol. But we are the most obese country on earth, with 38% of the population obese in 2015. Mexico came in at second place at 32.4% of the population being obese. In part because of this, Americans die of coronary artery disease, for example, at almost 3 times the rate that the French do, and more frequently than the OECD average. Another reason we aren't that healthy has to do with our unusual healthcare system. The US remains one of the only wealthy countries without universal healthcare. Healthcare provided to all citizens of a country regardless of ability to pay. For that reason, many of us face cost barriers when it comes to seeing a doctor or being treated. 14.7% of US adults aged 18 to 64 and 5.1% of children under 18 had no health insurance in 2019, according to the CDC. In a recent study conducted by the Commonwealth Fund, more than 30% of Americans with below average incomes and 10% with above average incomes said that they did not get some recommended test, treatment, or follow-up care because of the cost in the past year. Have you ever not gone to a doctor because you couldn't afford it? Many of us have. Our high rate of uninsured is also a major factor in why our healthcare system is so expensive. You'd think we'd save money by not covering everyone, but it's often the opposite. The expensive care means that we wait longer to seek help and are thus sicker and far more expensive to treat when we finally do show up at a doctor's office or the ER. For example, melanoma that can be treated quickly via a skin biopsy is pretty cheap to cure. If the patient waits until the cancer has spread to other parts of the body, not only is she more expensive to treat, she's also less likely to survive. One other unique feature of our health insurance system, and one that meant that the COVID-19 pandemic hit American families particularly hard, is that ESI, or employer sponsored insurance, is the most common way that Americans are insured. As of 2019, most working Americans, 69%, receive health care for themselves and their families through their employer. What happens to those people when a mass unemployment situation happens and they lose both their jobs and their coverage? That's what happened during the COVID pandemic. In the first 3 months of the pandemic alone, almost 50 million Americans lost their jobs. For millions of affected workers who depended on their employers for health care, that meant they were suddenly facing a deadly global pandemic without health coverage. I mentioned that our healthcare system is the most expensive per person in the world. But why? We don't even cover everyone. There are a number of reasons, and here are only a few. The first is high administrative costs. The American system, based on multiple insurers, builds in a lot of unnecessary bureaucracy. Duplicate processing of claims, large numbers of insurance products, complicated bill paying systems, and high marketing costs add up to huge administrative overhead. Administrative costs account for about 34% of healthcare expenditures in the United States, for example, whereas in Canada it's closer to 18%. Similarly, there is a problem with inefficiency. Providers must deal with complicated claims procedures of hundreds of different insurers, and most have to maintain staffs of dedicated medical billing experts to handle that. The third is profit. If you're running a healthcare system to make a profit, you need to charge more than things actually costs. The profits can be quite significant. In 2019, the top 7 insurance companies netted profits of $35 billion, and CEO compensation topped at about $36.5 million. Medical malpractice insurance and doctors' salaries play a role. Doctors make more in the United States, for example, but they also come out of medical school with more debt to pay off. University, graduate school, and medical school are all cheaper or even free in countries that subsidize the cost of higher ed more than we do. Finally, as mentioned before, uninsured or underinsured Americans are sicker and more expensive to treat by the time they finally go to the doctor. Another major factor is the cost of prescription drugs, and this is a big one. Most countries put caps on the amount of money that drug companies can charge for necessary medications. They can either do this by passing laws, or in countries where there is one health insurance provider, such as the NHS in the UK, the government will simply refuse to do business with any company charging higher than market rates. The United States doesn't do this, leaving pharma companies to pretty much set their own prices. For this reason, Americans pay between 80 and 150% more for prescription drugs on average compared to what people in Canada, France, Germany, or elsewhere pay for the exact same drugs. This can be life-threatening. One drug that is heavily affected is insulin, which type 1 and 2 diabetics depend on to control blood sugar. The cost of insulin in the United States is about 80 times that of other countries for the exact same drug from the same manufacturer. For that reason, a 2019 study conducted by researchers at Yale University found that as many as 25% of U.S. diabetics ration insulin, meaning they don't take it as often as they should or in lower doses than they should to extend their supply. Insofar as unmanaged diabetes can lead to outcomes including kidney failure, blindness, limb amputation, and death, this is a serious public health problem. Pharma companies argue that a benefit of making higher profits by charging more for drugs is that they can funnel some of that money back into research and development of new drugs. Developing new drugs is very important. We saw this with the global race to develop a COVID-19 vaccine. But on average, pharma companies spend only about 17% of their profits on research and development. Also, companies do get research revenue from other sources. The U.S. government spent about $2.5 billion helping to develop and then purchase the Moderna COVID vaccine, for example, and other funds came from private donors, including $1 million raised by and donated by country western singer and actress Dolly Parton. This brings us to the issue of healthcare reform. Some Americans have argued for the adoption of a so-called single-payer healthcare system. Single-payer healthcare is what you find in countries like Canada, the UK, or France. It describes a system in which health insurance is funded through taxes, guaranteed to all citizens, and run or administered by a single government agency, usually. We already have programs just like that. Medicare, which is tax-funded and run by the government to provide care to all citizens 65 and over, and Medicaid, which does the same for poor people who qualify. Politicians, usually left-leaning ones like Senator Bernie Sanders, have been advocating that we extend Medicare to cover everyone, what we call Medicare for all. Like I said, it's not a new idea. Countries like France and England have been doing it for decades. On this map, countries marked in green are those that offer some kind of universal, government-funded health care. These systems are not perfect. First, you have to pay for them. Plans like those proposed by Sanders would do so by raising taxes, mostly on the highest earners and corporations, and also by increasing payroll taxes paid by employers. Advocates of universal health care also point out, partially rightly, that our current system is so expensive and bloated and inefficient that getting rid of some of those inefficiencies would also help fund any kind of transition like this one. How well these systems work also depend on how well they're managed. The French single-payer healthcare system mostly works great. The Venezuelan system, which is impacted by the country's extreme poverty and extensive mismanagement and corruption, does not. Also, there are frustrations. Cost-cutting measures in national health systems, like those in Canada and the UK, can lead to people having to wait longer for specialist appointments or non-emergency surgeries. In the same way that people play multiple roles, as our genders, our races, our occupations, etc., being sick is its own role with its own expected behaviors, and a special set of rights and obligations, too. Sociologist Talcott Parsons was interested in the way that being sick functioned as a social role. He argued being sick created a temporary state of sanctioned deviance for the sick person. Once a person assumed the identity of a sick person, they could act in ways that they would not normally be allowed to. They could not go to work. They could sleep all day. They could be helped and cared for by other people. Even, in the case of long-term illness, be financially supported by other people. In some ways, being sick is pretty sweet. It's an excuse for almost anything. You don't have to return calls or emails. You don't have to be polite to people. You can even vomit on yourself and make other people clean it up for you. However, he argued, the sick person does have some obligations too. They must seek out care, follow doctor's orders, and try to get well. Even sickness or disease is socially constructed to some extent. And what I mean by that is, what we define as a disease or sickness is a social construct that can change across time. We call this process medicalization, the process by which human conditions come to be defined and treated as medical problems, i.e. diseases, and thus become the target of medical study or treatment. In the past, many diseases were viewed as markers of sin or immorality. You got the plague because God was angry with you, or you developed epilepsy because you were behaving in a way that was considered to be sexually deviant. We still do this with some diseases that are caused by biological factors. For example, some people still believe that cancer can be caused by repressed, negative, or angry thoughts, even though there's no scientific proof of that. And some things that we assume are non-pathological or natural now were once viewed as diseases. Homosexuality, for example, was seen as a psychiatric disease until the 1970s. Another example comes to us from the era of slavery. In 1851, a Mississippi doctor named S.A. Cartwright argued that there was a distinct mental illness, he called it drapetomania, that made slaves obsessed with running away. According to Cartwright, a psychologically healthy slave would be happy to be a slave and wouldn't try to escape. This is the example of the medicalization of something people in our time would see as a natural desire, to be free. It's also an example of what we call pseudoscience, a fake or fraudulent scientific claim. Because the sick role allows the individual benefits and freedoms not given to well people, some people may seek it out intentionally. This can lead to malingering, a situation in which a healthy person pretends to be sick for some secondary gain, such as fraud, for example, to bilk other people, insurance, or Social Security out of money. Access to opiate drugs can be another motivator. This is a major issue for ER docs and nurses and other medical care professionals who report frequent contact with patients who pretend to be sick or in pain so as to get access to narcotic drugs like oxycodone or morphine. In 2012, Physicians Weekly reported that as many as 20% of ER visits may be due to this kind of drug-seeking behavior. Malingerers may also pretend to be ill to get release from work or school obligations, or simply for attention and sympathy. Related to malingering are what mental health professionals call factitious disorder imposed on self, or factitious disorder imposed on others. conditions also popularly known as Munchausen syndrome or Munchausen syndrome by proxy. With these conditions, the affected individuals become so attached to the sick role and the sympathy, attention, and other benefits it provides them, they will deliberately harm or sicken themselves or someone else in their care, often leading to tragic outcomes. In 2015, a 27-year-old mother named Lacey Spears was found guilty of murdering her 5-year-old son, Garnett Spears, by poisoning him with a salt overdose through his gastric tube. Salt poisoning causes kidney and brain damage, as well as fluid buildup in the lungs. Lacey Spears was said to be a classic case of Munchausen syndrome by proxy. Though Garnett was seemingly born healthy, she began seeking medical attention for him shortly after his birth, claiming symptoms ranging from seizures to ear infections and dehydration, vomiting, and failure to thrive. In fact, it was claimed she'd used a variety of methods to induce most of those symptoms, as well as poisoning Garnett with high doses of salt to create abnormal findings on his lab tests. Garnett was subjected to repeated surgeries, including the installation of a gastric tube, supposedly because he had trouble eating, and a gastric surgery that prevented him from vomiting. Eventually, doctors treating him usually became suspicious and called Child Protective Services, at which point Lacey would simply pack Garnett up and move him to another state, starting all over again. CPS doesn't really have the mechanisms in place for tracking the welfare of children once they move to a new jurisdiction. Lacey had a blog devoted to tracking Garnett's medical emergencies and several different Facebook feeds, all of which did the same thing. Eventually, she amassed hundreds of followers with her stories of being a heroic single mom caring for a severely ill child. During the last week of his life, she pumped a heavy dose of salt water into his G-tube, it's alleged, and rushed him to the ER. He was stabilized, but admitted to the hospital, and video camera footage caught Spears allegedly dosing him with salt water through his G-tube again at various points during his hospitalization. Eventually, Garnett fell into a coma and died. Spears was prosecuted and given 20 years to life. Mental health is one very important facet of overall population health, even though mental illnesses and mood disorders are still less understood and often more stigmatized than illnesses that strike other parts of the body besides the brain. Approximately 17.9% of the U.S. population suffers from a diagnosable mental illness or mood disorder in any given year. Many of these will be mood disorders like depression, anxiety, or PTSD, post-traumatic stress disorder. Think about that. As a society, we still often feel shame about mental illness, but they are in fact incredibly common. Total lifetime risk may be as high as 46%. Meaning almost half of us will suffer from one of these conditions at some point during our lives. That's a pretty good argument for doing away with shame or stigma surrounding mental illness. The column on the right-hand side shows annual incidents broken down by most common diagnoses. Some evidence shows us that this problem may be getting worse. From 1999 through 2014, the age-adjusted suicide rate in the United States increased 24%, from 10.5 people per 100,000 in the population to 13 people per 100,000 in the population, with the pace of increase greater after 2006. Some populations and age group are at higher risk than others for committing suicide. Men, for example, commit suicide at about 4 times the rate than women do, and whites and Native Americans have the highest suicide rates of all racial groups. Most people assume that suicide is a disease of the young, and in fact, it is the second leading cause of death for people in the 15 to 34-year-old age group. But risks of suicide actually go up after middle age. In 2016, the highest total suicide rate was among adults aged 45 to 54, and the second highest of all age groups was in people over the age of 84. This chart shows male suicides by age per 100,000 of the population. The CDC data for Native Americans, light blue, are incomplete, but we see they have the most elevated risk as teens and young adults. Whites, shown in dark blue, come in second. For whites, blacks, Latinos, and Asians, the risk climbs with age, but not as severely as it does for whites, specifically white males. In many ways, white males enjoy more social advantages than other groups. They tend to have more financial resources, for example. But they also lead other groups in suicide risk. Why do you suppose that is? One reason may be, simply, that whites tend to be less connected to families than other racial groups and more socially isolated, especially as they age. Elderly whites, for example, are more likely to need to depend on nursing home care or no care at all as they age, whereas other racial groups are still more likely to care for aged relatives in their homes. Males also tend to be less likely to ask for help when they are feeling depressed, and they're more likely to use more lethal means to end their lives, like guns. Risk of suicide actually rises with age then, peaking in the 75 plus age group. Many elderly people may have undiagnosed or untreated depression, which can be intensified by the trauma of losing a spouse or the stress of living with a chronic illness. Elderly adults often lack frequent social interactions that can help protect them against the loneliness that can exacerbate depression. Other risk factors include gender, with men at higher risk than women, and race, with whites and Native Americans experiencing higher risk. Social isolation, as a whole, is also a risk factor. GLBT, gay, lesbian, bisexual, and transgender populations show elevated rates of suicidality, possibly due to stress or social rejection, as do military personnel and police and other first responders, likely due to a combination of both job stress and trauma and access to lethal means like guns. Another suicide risk factor is simply exposure to other high profile or well publicized suicides. This phenomenon is called suicide contagion. For the suicidal person, other suicides may simply reinforce the perception that suicide is a reasonable or good solution to their problems. The death by suicide of celebrity Robin Williams, for example, was followed by a noticeable spike in suicides in the general population, accounting for as many as 2,000 additional deaths by suicide. One final potential risk factor for suicide has more to do with method than motivation. The simple presence of a gun in the home increases an individual's risk of committing suicide, and suicide rates actually vary by state, with higher levels of home gun ownership correlating with higher suicide rates. Why? Because guns are simply more likely to be fatal. Other methods of suicide, like overdosing or cutting, are less lethal, both because they are more likely to fail. Your body has defenses against overdosing, for example, like involuntary vomiting, and because they give the individual time to second guess their decision and call for help. A study conducted by Harvard's T.H. Chan School of Public Health in 2000 estimated that while less than 5% of suicide attempts by cutting or overdose ended up being fatal, over 82% of suicides by gunshot were. The good news is, more than 90% of people that survive a suicide attempt will never end up taking their own lives. They get help, the crisis passes, and eventually they get better. So if someone you care about is showing symptoms of suicidality or severe depression, and there is a gun in the house, limit their access to it and get them help. To learn more about symptoms of suicidality or get resources if you or someone you care about is potentially suffering from this, please visit the National Suicide Prevention Lifeline, URL and phone number shown here. One other significant social problem in the United States relates to how we as a society care for people with severe, long-term mental illness. Whereas suicidality or major depression is often a short-term condition that a person will recover from, certain kinds of mental illnesses may be lifelong conditions that interfere with the individual's ability to hold down a job or live independently. Such individuals are an especially vulnerable population. Before the 1960s and 70s, it was common for people with lifelong, severe mental illnesses, like severe schizophrenia, to live in institutions, psychiatric hospitals, or what were sometimes called insane asylums. Deinstitutionalization describes a social process of shifting care for the mentally ill from inpatient psychiatric hospitals to outpatient care programs, or unfortunately, often no sustained treatment at all. The process of deinstitutionalization, the closing down of psychiatric hospitals, really began in earnest in the US in the 1960s and 1970s and was a result of several factors. Investigative journalism, academic ethnography, and in some cases fictional explorations, such as the novel and then movie One Flew Over the Cuckoo's Nest, of conditions in so-called insane asylums or mental hospitals, began to raise public awareness of the terrible, often abusive conditions in these facilities. The invention of the first psychotropic drugs in the 1950s, like the antipsychotic Thorazine, also allowed for some hope that conditions like schizophrenia could be managed effectively enough that the sufferer could live a normal and productive life. Finally, changes in federal and state funding for the treatment of vulnerable mentally ill populations stripped away financial resources that formerly supported the care of these populations. One practice that drove public demand for changes in mental health treatment was the abuse of so-called civil or involuntary commitment. We still have involuntary commitment for the mentally ill today, but before the 1950s, there was no professional consensus over when it was appropriate and no court-supervised process for depriving a person who had not committed a crime but was nonetheless considered to be unable to care for themselves due to reasons of mental defect or illness of their most basic freedoms. As a result, people could be locked away in psychiatric institutions for years on the say-so of a single doctor or family member. It was a system ripe for abuse, and it often was. This lady is a good example. Elizabeth Parsons Ware Packard was an outspoken and opinionated woman in an unhappy marriage. Her husband, Theophilus Packard, was a minister, and he objected mightily to his wife's strong opinions on religion. Apparently, she began disagreeing with his interpretation of certain scriptures and let him know it. She also resisted his authority on a number of other matters and complained publicly about his domineering and abusive ways. The Reverend Packard took advantage of an Illinois law that allowed a husband to have his wife involuntarily committed without either a hearing or her consent. He approached a doctor who agreed with his assessment that a lady who talked back to her husband must be insane, and she was locked away for 3 years. When she was finally declared sane by the asylum doctors and released, she found herself stripped of all her property and was denied visitation with her children. She spent the rest of her life fighting for women's rights and the rights of the so-called insane. In our time, involuntary commitment does still exist, but it is temporary and requires court oversight. It's good that we aren't as quick to institutionalize someone without due process. But because deinstitutionalization was not followed by the creation of enough community-based treatment options, the seriously mentally ill were released from asylums in many cases and left to live on the streets. People with severe mental illness are thought to be only about 6% of the population, but they make up an estimated 25% of the homeless population. They are also overrepresented in prisons. Mentally ill people are not usually dangerous. They are far more likely to be victims of crimes than perpetrators. So when they do end up in prison, it isn't usually for committing violent crimes. Usually it's for more minor offenses, trespassing, shoplifting, for example, simply to get something to eat, or parole violations because they can't stick to their release conditions from previous prison stints. Some, for example, may drink or use drugs to self-medicate, or they may be unable to keep appointments with parole officers or counselors. In order to be considered to have adequate mental health facilities, a state should have about 50 inpatient psychiatric treatment beds per 100,000 of the population. No state has that many, but Texas is ranked 42nd in the nation, with 8 beds per 100,000 people in our population. A seriously mentally ill person in Texas is 8 times more likely to end up in prison than they are to end up in a mental health facility. Deinstitutionalization and the overrepresentation of the seriously mentally ill among the homeless and in prison is thought to be one reason that the U.S. prison population rose so much starting in the 1970s, shown here in this graph from the Sentencing Project. It isn't the only one. Other factors include legislative changes, like the so-called war on drugs. With the long-term care of the severely mentally ill, the question becomes, how do you balance individual freedom with the moral requirement to take care of our society's most vulnerable people? And, just as significantly, are we willing to fund it? These are questions we, as a society, have not yet answered. This concludes this lecture on the sociology of health. Thank you for listening.